90% of people who suffer cardiac arrest outside a hospital will die. But when a specific chain of factors lines up, survival soars past 40%. We're counting down 10 critical factors that determine who lives and who doesn't, ranging from split-second decisions at the moment of collapse to advanced hospital interventions most people have never heard of. It all begins with one deceptively simple variable at number 10. In the 10th place, the earliest division between life and death happens at the exact second of collapse, long before anyone reaches for a phone or begins chest compressions. It comes down to whether anyone actually sees the emergency happen. National registries show a stark divide. Unwitnessed cardiac arrests carry a survival rate of just 4.3%. But when someone witnesses the collapse, survival rates rise to 16.1%. If that witness immediately starts CPR, survival climbs to 37%. Location dictates whether anyone is present to recognize the crisis. An unwitnessed collapse often goes unnoticed for minutes, letting the brain starve of oxygen and allowing the heart rhythm to deteriorate before help is even summoned. It is the first major split in survival, occurring before medical treatment even begins. Number 9. Dispatcher-assisted CPR. When cardiac arrest strikes, bystanders often freeze out of fear of doing harm. This intervention acts as a direct bridge, removing the fatal delay before emergency medical teams arrive. When a caller dials 911, dispatchers immediately deliver clear, urgent instructions over the phone, telling the bystander to place the heel of their hand in the center of the chest and push hard and fast. By coaching the caller to perform continuous chest compressions at a rate of 100 to 120 beats per minute, dispatchers bypass the hesitation that so often dooms a patient. This guidance does not replace advanced medical care, but it keeps oxygenated blood flowing to the brain during the initial minutes when survival hangs in the balance. 8th place, hands-only bystander CPR. When the heart suddenly stops, the clock instantly starts ticking against brain survival. Performing immediate chest compressions is the single most powerful action a layperson can deliver before professional help arrives. By pushing hard and fast in the center of the chest at a rate of 100 to 120 beats per minute, any bystander physically takes over the pumping action of the heart. This manual circulation keeps a continuous flow of oxygenated blood moving to the brain and cardiac tissues, keeping them viable. Medical registries confirm that starting bystander CPR roughly triples the odds of surviving the event with good neurological function, turning what could be a fatal delay into a window of hope. Number 7. The quality of the chest compressions themselves. Simply performing CPR is not enough. The raw physics of the technique dictate how much oxygenated blood actually reaches the brain. To keep the heart and brain alive, compressions must reach a precise depth of 5 to 6 centimeters. Pushing too shallow fails to squeeze the heart, while pushing too deep causes severe internal injuries. Speed is also essential, requiring a steady pace of 100 to 120 compressions per minute. Every stroke requires the chest to fully recoil at the top, allowing the heart chambers to refill with blood before the next downward push. When rescuers rush or fail to release their pressure, blood flow falls to near zero, making physical technique a direct determinant of survival. Number 6. Shockable rhythms. When the heart suddenly stops, its actual electrical state dictates whether a patient can be pulled back from the brink of death. Shockable rhythms, specifically ventricular fibrillation and pulseless ventricular tachycardia, represent a clear biological window. In these states, the heart has not completely flatlined. Instead, its electrical signals are firing in a chaotic, rapid frenzy that prevents the muscle from pumping blood. Because an active, albeit disorganized, electrical pattern still exists, a defibrillator can deliver a high-energy charge to completely reset the system, allowing the heart's natural pacemaker to regain control. This category offers a fundamentally better rescue opportunity. In fact, patients presenting with a shockable rhythm have a survival to discharge rate of about 42.6%, making this electrical state a major factor in survivability. Number 5. Non-shockable rhythms. While cardiac fibrillation, called CF, presents a chaotic electrical state that can be shocked, asystole and pulseless electrical activity represent the opposite side of the rhythm divide. In pulseless electrical activity, called PEA, the heart shows organized electrical signals on an ECG, but the cardiac muscle fails to contract and generate a pulse. A systole, the classic flatline, means there is no electrical activity at all to reset. Because there is no active electrical rhythm to disrupt, delivering a shock cannot solve the problem. Rescuers must rely entirely on high-quality CPR and medications, which explains why the survival to discharge rate for these non-shockable rhythms drops to just 8.8%. Number 4. Having a shockable rhythm is only half the battle. The timing of the electrical shock determines whether the heart actually restarts. During cardiac arrest, survival operates on a steep, unforgiving curve. Every single minute that passes without defibrillation reduces the chance of a favorable recovery by approximately 10%. If a patient in ventricular fibrillation receives a shock within the first 60 seconds of collapsing, their survival rate stands at roughly 40%. However, if 10 minutes pass without treatment, that probability plummets to less than 5%. This rapid deterioration occurs because the heart muscle depletes its remaining oxygen and energy reserves with every passing second, leaving the brain starving for blood. The window of opportunity closes in real time, making sheer speed the ultimate factor. In third place, public access automated external defibrillators turn the critical time-to-shock timeline into a simple matter of geography. Simply owning a device is useless if bystanders cannot locate it. True survivability depends on placement density, clear signage, and rapid retrieval. When a device is positioned nearby and clearly marked, ordinary people can deliver a shock before paramedics even arrive. The real-world outcomes of these public access programs are stark. In major airports, witnessed cardiac arrests that receive an immediate shock achieve a 75% survival rate. Similarly, casino safety programs show survival rates of around 70%, compared to under 10% in venues lacking these devices. This makes physical accessibility a separate survival factor from the treatment timeline itself. In second place, obtaining a pulse does not guarantee that a patient will recover. Once the heart restarts, the brain remains highly vulnerable to injury caused by the sudden return of oxygenated blood. Targeted temperature management acts as a neurological shield, but clinical trials show its application is surprisingly precise. The landmark TTM-1 trial found no survival or neurological advantage in cooling comatose patients to 33 degrees Celsius versus 36 degrees Celsius. The larger TTM-2 trial confirmed that routine cooling to 33 degrees Celsius offers no benefit over keeping body temperature normal and preventing fevers. Still, cooling has a role. The Hyperion trial showed that cooling to 33 degrees Celsius modestly improves neurological outcomes, specifically for those who suffered non-shockable arrests. Post-arrest care is about precise, individualized medicine. And finally, in first place, cath lab access and post-arrest care bundles. Once the heart is restarted, the final outcome depends entirely on what happens in the hospital. If an electrocardiogram shows an ST elevation myocardial infarction, doctors must activate the cath lab within 30 minutes to clear the blocked artery. However, for patients without clear ST elevation myocardial infarction evidence, the landmark COACT trial revealed no universal benefit to rushing immediately to the cath lab, meaning doctors can safely stabilize the patient first. Survival ultimately relies on specialized cardiac arrest centers. By bundling targeted temperature management, blood pressure optimization, and multidisciplinary care in the intensive care unit, these centers double the rates of neurologically intact survival, raising favorable discharge rates from 15% to over 30%. This coordinated hospital phase is what ultimately secures a second chance at life. Across these 10 entries, one truth emerges. Survival is not luck, but a flawless chain of timing. From bystander action to advanced hospital care, every second is a link that cannot break. Life depends on a system, not a miracle. Have you ever learned CPR? Let us know below.